I applaud you for doing that remotely and seamlessly on the slides. And it's a lot to think about. We have time for a few questions. I think both Melinda and Alan put out some challenges to us, right? They asked many more questions than they answered. So let's take a few minutes before we break to ask them questions, comments. Please identify yourself and come to the mics.
Hi, Amy Compton-Phillips with Kaiser Permanente, and thank you both for really great information. And I'm wondering in the models if you have any place that you've actually been thinking about the impact of geography, zip code. We've done a lot of work that shows really your zip code is more associated with your risk of long-term death than even the number of conditions that you have. Because of the incredible impact of the social circumstances. So, and love the concept in yours, Alan, of the medical neighborhood, but wonder if there's anything to be done with building the capacity and infrastructure within the actual neighborhood as well.
So let's start with Melinda, and then Alan, you can jump in.
Okay.
I see. So we are in the process right now working with our scorecard team. The Commonwealth Fund has released a number of national, state, and local scorecards, and actually trying to think about and analyzing some of this data at a local level or a state level or a regional level. There are obviously some data limitations. So one is, yes, we're thinking about it. No, I don't have the answer. But certainly we know there's enormous variation for a lot of the services provided to this population, work done actually by the IOM, on post-acute care and how much, kind of that also varies by region, but a number of other things certainly. Yeah.
Right. One of the main reasons I'm asking is back to the question about learning from the individuals that we serve. In the areas that we've been addressing, focused on these events, actually going to the community and having the community design the solutions was actually infinitely more effective than us treating it from a medical perspective.
Absolutely. And that's why I was just going to, the Betsy Bradley project, which I referenced very briefly, she will be looking at the community level and looking at the whole set of resources and trying to identify through case studies and interviews kind of factors and attributes of what seems to be more associated with better outcomes and lower costs for similarly situated patients. But I think Alan probably has a lot of practical experience.
Yeah, so let me talk about two different things in regards to this. One of them is, the great work done originally in Camden through the Camden Coalition and Jeff Brenner, and that was geo-mapping where people lived and then bringing services to the housing projects, including primary care, for the patients who are going to the emergency room 200 times a year. And a lot of it, again, what may seem crazy from the outside, if you looked at those individuals, they were getting their needs met in the best way that they could within the current system. It just happened to be very expensive. So that's one thing, is to map people. But what I think mapping shows, and geography is destiny, has been known in healthcare for a while. But it's associative but not causative. And what we're seeing with geography is destiny is a proxy for adverse childhood experiences. And I think the causative event that occurs in certain geography is the trauma of living within certain households within that geography. And it doesn't come from the soil per se, though I could imagine, lead poisoning and other things that I would have to take that back. It's much more that the rate of ACE is much higher in certain places than others. And, if you look at homeless populations, and Rebecca Ramsey, I know, is talking later in the day, if you look at homeless populations, 99% have had high adverse childhood experiences as their background. And so I think the causative entity that's leading to the geography as destiny is something that's very specific to an individual and more likely to occur in some neighborhoods than others. And there's an urban version of the ACE study now that includes things like drive-by shootings. And I think it's more valuable in an urban environment. It's certainly what the Camden Coalition is using to look at their own population right now. But I think we need to understand what are actually the drivers of those high costs in those neighborhoods, rather than go, oh my, it's poverty and there's nothing to be done. because it turns out there is a lot to be done for ACE survivors. And that our patients are people who survived that childhood largely, made it to 40 or 50, can be very accomplished in their lives, but something starts breaking, and often it's their health that is the one area that has been a victim. Morbid obesity, smoking, not taking care of themselves, depression. All of those things are what are associated with bad outcomes. And then even within children, not the adult survivors, but within the little kids, people such as Nadine Burke out in San Francisco in Baby Hunter's Point is showing that she can intervene, her program can intervene right at the time it's happening and have a great effect. So I think that's a major part of this work is sort of how do we intervene with damaged people who you can't undo the past, but you can reprocess it and learn to live within it. So I really think that's what the geography issue is mostly about.
I think we'll come back to that one. I'm sure that's one that the root cause is understanding it. We'll have time for 2 more questions here, and then brief we can do.
Hi, I'm Joanne Lynn from Alterum Institute Center for Elder Care and Advanced Illness. We've been working mainly on the subcategory of frailty and old age. There's a subtle difference, I think, between finding the high-cost patient and finding the people with similar needs, some of whom are not yet or may never be high cost. And when we design care systems, it seems that the relevant piece is the person's situation, their medical situation, their social situation, and so forth, to find the right category. And I'm worried about us kind of developing care systems around proven ability to run up big bills rather than sort of the person's basic characteristics. So if you build a care system for frail elders, you're going to include 10 or 15% who are very low expenditure. But they need the same sorts of services to be at the doctor's beck and call or at the community health worker's beck and call, whoever it is. I mean, they need the same services. So just a caution that it may be the kinds of people rather than their proven ability to run up bills that we wanted to really search.
And I also heard prospective versus retrospective understanding. Any response, Melinda?
I don't actually disagree, and I hope that my comments actually didn't kind of try. I was trying really hard, in fact, to stress the point that it should be driven a lot by need. I think that there is, though, looking at that intersection of need and cost is valuable, but it's maybe not, and I guess that's maybe where your comment comes from. But I do think it is driven very much about the need. I think the whole retrospective, prospective versus present condition, kind of looking at your attributed patient population and segmenting and figuring out programs for those with existing needs versus those who seem to have needs, using kind of a lot of predictive analytics to try to figure out who might be really high need in the future. I think there are a lot of compelling arguments there. I think at the risk of sounding somewhat potentially controversial, I was recently at a meeting that we convened, and it included Independence at Home, Montefiore, Camden Coalition, and Hennepin. And essentially they said, we could spend a lot of money on predictive analytics. And the truth is that our best way to predict people's needs is to look at where they are today. And kind of we could look retrospectively past 4 or 5 years to help us with planning for workforce, but in terms of trying to figure out kind of where an individual patient or a cluster of patients may be, it's really hard, and your best bet is looking at those right in front of you. Conceptually, I love the idea, if we have the resources, to kind of start 0 to 3, with the 0 to 3 population, and kind of really start early and thinking about prevention. That's where I think, but in terms of affordability and where the system is and some of the current incentives are, I think looking 1 to 3 years in terms of cost ahead, I think also is the reality that we are living with.
All right. With us health services researcher, she didn't do away with predictive analytics. I have a health services researcher by training, so there's still room for health services research. Alan, do you have a brief response, or?
Yeah, it's a very pertinent issue, and we're at a place like Stanford where there's a healthy margin and the ability to invest in workforce. We're having to try to demonstrate our value with an insufficient N and a population where the great majority of people were levels 3 and 4 coming in, which removed a lot of the easy savings. And an easy savings example is somebody going to the ER all the time because they can't reach their doc at night. So, we all take our call on our own patients. There are things that are easier and things that are harder lifts, and the easy lifts are hard to do at Stanford. So what I really think what we need is some metric which is not based on let's look back and tell us what the ROI was in year one. And I think the patient activation measure change may be exactly that. So, and we're about to convene a whole conference about it with the author of the work. But more importantly, I think the workforce that does this work has to be as lean as it possibly can be. And that means using a workforce that's not the typical healthcare licensed workforce whenever possible. In our program, we use medical assistants, who are people with a high school degree who we've hired for empathy, trained up to be very, very useful, and they have their own panel of patients and operate, essentially like community health outreach workers. But the community that we're outreaching is Stanford University. Right, and so the best place to have them is on campus, not roaming around neighborhoods. But it's again the principle of how can you use an unusual workforce, train them, and have it be useful. We only have one nurse in our program. It isn't that the nurses do the case management. It's done by the care coordinators. We have physicians, but the physicians do only things that physicians can do. And I think if we force ourselves to be as lean as possible in the work rather than building, a regulatory environment that says this has to be done by a nurse or this has to be done by a doctor, we will find this a much more affordable piece of work than if we continue to deliver care through the expensive personnel that we traditionally have.
And I think we'll come back to the standardization flexibility issue. We'll keep recurring as where you need standardization and where flexibility. Last comment here.
Thanks. Dr. Robert Green, Executive Vice President and Chief Population Health Management Officer at Dartmouth-Hitchcock Health. So for Dr. Glaseroff, I was really impressed by your studies. Thank you very much for bringing attention to the effect of regression to the mean. And there was an early slide which showed a result that was a 20% decrease, but the p-value was only 0.11. So I guess I have a practical question. I'd be interested in your views, and also perhaps a question the rest of us should ponder, which is how low a p-value do we really need? If it's a well-designed study, personally, if it's a well-designed study and it had a p-value of 0.1, I'd say, gee, that's a pretty good result. So that's my question for Dr. Glaseroff and others.
Yeah, I appreciate that question because it's actually a conversation that very much will determine the future of my program. The notion of 89% likely to be true being no progress is interesting, and I think in a meeting that was held at Stanford at Arnie Milstein's Clinical Excellence Research Center with Nitish Chowdhury. His quote was, "There is no denominator large enough in the universe to really prove savings because spend is so erratic. It doesn't happen, it doesn't happen, it doesn't happen." And then we had a patient who had a heart transplant. In a single month, $1.5 million were spent on her. And she's alive and well and back at work. It's a miracle. It's amazing what Stanford can do. We helped her to get to that point in as lean a way as possible because we started when she began. She was symptomatic and not yet diagnosed. And that blew whatever savings we might have achieved on every other patient for the entire year.
Sorry, Jeremy, full employment for economists, health economists, you heard it here. Predictive analytics, we're not so sure. Biostatisticians and economists, I think we've got full employment. So Melinda has a last word, and then we'll do a break here.
I guess all I would say on that question, I think it's something we all struggle with, especially those of us that fund evaluations of a lot of these kinds of studies. And while a lot of times it requires larger sample sizes that we cannot afford, what I would say is, and maybe at some point the Bipartisan Policy Center could also weigh in on this, is that if it also comes down to the preponderance of evidence, that if there are a repeated number of studies that are directionally similar, and many of which have statistically significant findings, but some that are just directionally meaningful, you know, I think when I've talked to colleagues at CBO and OMB, they don't live or die by 0.05. And so I think that we need to continue to work harder, to still design elegant studies, and just have a lot of them and try to power them up as much as we can.
Perfect. Let's thank our two presenters.